Welcome everyone to the World Health Summit and our panel discussion on radiotherapy as an essential component of cancer control. My name is Julie Terode. I'm Director of Special Projects at Union for International Cancer Control, UICC, and I'll be your moderator for today. The 43.8 million persons around the world living with cancer who are diagnosed within the last 5 years only demonstrate that cancer is a substantial social and economic burden in all countries, regardless of development. The International Agency for Research on Cancer projects that by 2030, over 24 million people will be diagnosed with cancer and 30 million people will die from the disease every year. A rise from the 18 million diagnoses and the 9 million deaths today. These are largely premature deaths, and this rising cancer burden will take its toll in low and middle-income countries especially, many of which are struggling today to deal with the present situation. On the bright side, the number and extent of implementation of national cancer control plans has increased in recent years, driving access to health technologies and diagnostics for quality and cost-effective treatment and palliative care. This promises millions of cancer patients life-saving services for the first time. Our panelists today will share perspectives on good progress at national level and highlight innovations which will help address the challenges as countries respond to this growing burden. You will see today we have a strong panel of experts. Can you put the slide up, please? In the interest of time, I won't introduce each of them now, but as they turn to speak, I will do so. So welcome everyone to our panelists. Thank you for joining us on this discussion. We invite you as our audience to also participate by sharing comments or questions in the chat function. We will try to include as many as we go along, but we will also have a dedicated question and answer segment towards the end of our 90 minutes. Before we go on, I'd like to show you a short film to set the scene for those of you that are less familiar with the role of diagnostics and radiotherapy in cancer control. Could you roll the film, please? It gives me great pleasure to introduce one of our co-hosts for this session, Rafael Grossi, Director General of the International Atomic Energy Agency, IAEA. DG Grossi, firstly, thank you for the film. The IAEA has mainly been known as the world's nuclear watchdog. Can you give us some information about the lesser known role of the agency in health development and cooperation? And also give us some of your insights into what your agency does to accelerate introduction and scale up of diagnostics and treatment services in low middle-income countries.
Well, Julie, thank you very much. It is really a pleasure to be with you today, your co-host, Anya, my colleague, and also such a nice panel. I think, let me commend you for the diversity of this panel. We are mixing private sector, public sector, international civil servants. I think is a very nice way to exemplify how we work together from different angles. on this very pressing issue. And I thank you also for the opportunity to share with the participants some of our experiences and what we are doing from the IAEA. Of course, the IAEA has this image, reputation of being the nuclear watchdog, and normally we are identified with geopolitical issues and matters related to non-proliferation and nuclear weapons. But for those who have been working in this field of nuclear medicine, radiation therapy, know the IAEA has been very active in this field for more than 6 decades, helping basically countries to use radiotherapy and nuclear medicine. Radiotherapy is, of course, essential in the treatment of cancer. And as you know, by any normal estimation, more than half of all cancer patients benefit from radiotherapy. However, we also know that access to radiotherapy is still limited, especially as the film you just showed reflected, especially in low and middle income countries. So a few numbers may give a good idea of what we are talking about, the dimension of the problem. 1 country in 4 does not have any access at all to radiotherapy services. And nearly half of the countries in Africa, imagine the African map, half of Africa does not have a single radiotherapy machine. So it is obvious that thousands of additional radiotherapy machines and substantial staff training are really required to address this issue and the current shortages in least developing countries. This is something where with concerted effort, with political will, with determination, with creative partnerships with the private sector, I think we can improve, and quite fast. We have been concentrating in our work on cervical cancer, which is an area where we believe that the positive effects of a concerted, decisive action could be felt very, very fast. Cervical cancer is the 4th most common cancer in women in the world. It is a disease that kills more than 300,000 women every year. And the thing is, to stress the point that I just made even more, than 90% of this already huge amount, 90%, live in low and middle income countries. The summit takes place in Berlin. I work in Vienna, in Austria. In these countries, cervical cancer is serious, but normally you will not die from it. In developing countries, in low, middle income countries, such diagnostic could be like a death sentence. And the solution to this problem, there are problems that are beyond our ability to influence and to change things. But this is one problem where we can make a difference with the increase of access to radiotherapy. And this is what we are trying to do by partnering with you. So increasing access will help support also the new WHO global strategy for the elimination of cervical cancer. I would like to stress this, especially these days. The IAEA sees itself as a partner. We are not the main health organization in the world, but we have a lot to do and a lot to contribute to in this global effort. And this is what is needed at this moment. We have to join hands, work together, and we are bringing our experience from our side of the issue. So the idea is to help countries achieve the targets set out in the Sustainable Development Goal number 3, as you know, which is reduce premature mortality from non-communicable diseases, including cancer, of course, by 1/3. Achieving this by 2030, as is envisaged, will require enhanced access to radiotherapy. So all of us should do better than we are doing. So this is why cancer control in developing countries in particular is one of the strong focus of the IAEA work. We have, as you know, a technical cooperation program through which we have spent over 172 million in support, specifically in support of cancer-related projects. More than 2,000 health professionals have been trained already through fellowships and scientific visits. So this is, of course, much more is needed. We also help countries when they set up their facilities and acquire the equipment. So this is another area. One interesting thing these days, where, of course, COVID-19 is in everybody's minds, and rightly so, is that for this period, we decided to conduct a survey of nuclear medicine departments in 72 countries. This was published in the Journal of Nuclear Medicine last month. And I would like to share with you some of the findings that this survey conducted by my colleagues in the agency with the help of these 70-something institutions show. Well, the first thing is that the number of procedures, cancer, fell dramatically because of the pandemic. A few figures. The number of lung scans fell an average of 56%. Bone scans, 60%. And the number of heart studies, 66%. Many countries, especially in Africa, Asia, and Latin America, reported, of course, difficulties in obtaining supplies of medical radioisotopes and generators. Of course, this is very worrisome, and we will continue focusing on this so that, in spite of the priority of the pandemic, this does not get any worse, and it's actually redressed. We are trying to bring even closer together the research institutions supporting multi-country research projects on improving diagnosis and treatment. For this to be effective, of course, one must know who is doing what in the world. So this is why we are maintaining a tool that I recommend to you and to other participants, which is called DIRAC. This is the Directory of Radiotherapy Centers. It's very important because through this we have a sort of an inventory, a telephone book, if you want, more than that, of the institutions around the world that are available for this. We also developed an interactive, comprehensive e-learning platform which integrates all necessary radiation medicine training resources. This is also very important. And in fact, in these days and this meeting is an example, unfortunately, so much goes virtual. In these cases, we were already doing it because we know we have to reach out to faraway places, to places that are isolated, don't have the money or the resources to get the advice and the support that they need. And this is why I've been trying, and I'm glad to see that you have our colleagues from Varian in the panel. I've been promoting quite, I don't want to use the word aggressively, which is used normally in these analogies, but quite actively all sorts of partnerships, and in particular with the private sector, because it is obvious that for organizations like the IAEA, assess contributions and access to public funding is becoming more and more difficult because of the multiplying priorities that countries have, and also because of the financial crisis exacerbated by the pandemic. So we need to pull together. Thanks to recent technological advances, radiotherapy is now more precise and more effective than ever before, with fewer side effects and less time needed to deliver therapy. So we can also benefit from such technologies as artificial intelligence and making radiotherapy treatment more accurate and personalized. Artificial intelligence can also be very cost-effective in the education and training of medical professionals, especially again in least developed countries. Virtual reality techniques can help to alleviate patients' anxiety by letting them have access to treatment process virtually before the real treatment takes place. So this is another benefit. So rounding up my thoughts, the agency is trying to be active where it can make a difference. We are trying to partner with you, with all those generously committed to this task. And we are willing to learn from others and to tell them that in the IAEA, they have a great group of technicians, technologists, and scientists that want to play a role in this indispensable task. So I hope these very general remarks can give you an idea of why we are so committed, we are so passionate at the IAEA about even doing more on this issue. I'm sure that later on in the questions and answers on the interactive part of our panel, if we have time, I'll be able hopefully to tell you a little bit more. But thank you for the opportunity in any case, Judy.
Thank you very much, DG Grossi. One quick question, an obvious one maybe, particularly with the statistics that you just shared. 1 in 4 countries currently having no access to radiotherapy, and 50% of countries in Africa. Very simple question come through in the chat. Is there an alternative to radiotherapy? So can these countries do anything else?
Well, I would say that radiotherapy is needed. I don't know if one could say is indispensable. I'm not a medical doctor. I can say that is indispensable. And we need to, while thinking about alternatives, if they exist, we need to make sure, because it is not impossible to make this accessible. This is my point. We don't proceed from the assumption that this is an impossible goal, that this is for the rich countries, and poor areas of the world should content themselves with less accurate, efficient therapy. No, it's not the case. This, in fact, this is such a scandal because it's a low-hanging fruit. It's something we can do with relatively modest, I would say, funding, the progress we could make by adding in this half of Africa, a radiotherapy unit in some sub-regions, so people do not need to fly to Paris or to whatever metropolis they could have had in the past. So this, we have to stop with this. And so apart from therapeutic alternatives on which, as a non-medical person, I wouldn't dare to have a view. Where I have a view is that we know that radiotherapy is accessible, radiotherapy is deliverable, and the only thing that we should do is to get together to get the resources. And of course, we can complement it, as I was making reference to, with all sorts of virtual support. We have, I can describe that a little bit better later on, but we have the virtual tumor boards and things like this, which are enormously helpful and are considered, you know, a therapeutic approach or as part of the cure, if I can put it in a layman's words. So there is a lot. I think we should not drop the ball here. We should concentrate on what is possible and just improve it.
So thank you very much, Didi Grossi. I'm also not a medical person, but as a cancer advocate, I applaud your very clear words on the sense of urgency and the positivity that we can actually provide all countries with access to radiotherapy. So very much a collaborative approach and with a focus on training and capacity building. So thank you for that. And I will come back to you later. Let's hear now from a country perspective. I would like to invite His Excellency, Dr. Ruiz Gomez, Minister of Health of Colombia, who will give us a keynote presentation on progress in cancer control in Colombia. Over to you, Minister. And can we pull up the slides for Minister Gomez, please?
Hello, Julie. Nice to meet you. Very thanks for your invitation to this panel on a very important issue like radiation therapy in Colombia, in the world, and of course in Colombia. I will make a very short presentation about Colombia. First, I will say that the cancer situation in Colombia, next please, reflects, no, maybe I should go back in the presentation, please, back, please, back, okay. Oh, okay, next, no problem. Okay, next please. Maybe I will say that in Colombia, the cancer situation in the Colombia, it's they corresponded to the situation of a country with a high mortality, with a middle mortality. Colombian incidence of cancer is in the middle between countries, less developed countries and developed countries. We have every year at least 130,000 new cases of cancer in our country. Mostly throughout the country, but we have a larger incidence in cities and urban areas. And we will say the cancer mortality in our country, it tends to be lower than those in other Latin American countries. That is, if we add the most of the cancers in our country. This is the speed, the aging of our population. Mortality from cancer in both sexes is below in the regional average, reflecting the impact of universal coverage that Colombia has already attained. About 96% of Colombian population is now covered by a health insurance. We can see, unless that people treated next one with cancer is growing. Next one, next please. Next. Next, please. We have, back please. The universal coverage in Colombia is around 96% of the population. Even the poorest population in Colombia has now a coverage of health insurance. This has made a strong difference in the access to health services in Colombia and with increased access, of course, for people with cancer. Next one. Next, please. That leads for a very important issue that the financial protection for people in cancer in Colombia is very high. Just 16% of total health expenses in Colombia are out of the pocket expenses. That means that social insurance have can protect the the families, Colombian families, in their expenses about with cancer and with other diseases. Next one, please. Uh, the spending for cancer from the whole country have increased, have been very high in higher in some cancers like colorectal, lymphoma, and cervical cancer. Leukemia is also increasing especially in children, and we now have in children, especially we have around 2,000 new cases of leukemia per year in Colombia. Next one, please. From our services, mostly 14% of our service are surgical service, 68% are extensive consultation service, and 16% are diagnostic support services. These have to be with a very important issue that we have in Colombia right now, and maybe is the most important policy area to develop in the next future. And I will talk about health services fragmentation. In Colombia, we have both private and public services. They are integrated in comprehensive networks, but we are facing problems with cancer treatment because we have a lot of ambulatory units with no integration direct with radiotherapy, chemotherapy, and other associated services. This is our frontier to work for the next years. In Colombia, we have about around 60 accelerators for the whole country. For a 50 million population, that means maybe we have one accelerator almost per million people. That's very low rate, and we need to increase this in the next future. But to increase that, we need to assure that all cancer services in Colombia are integrated. And this is a big challenge for the next future. Next one. What is the Colombian government strategy for control of cancer? Next one, please. Of course, primary prevention with control of tobacco, physical activity, reduction of alcohol consumption, and vaccination, especially for hepatitis B virus and papillomavirus, human papillomavirus. These two vaccination programs are in course now in Colombia, and we are working very hard on them. Next one, please. We also have in our policy some goals for increasing the cervical cancer screening, increasing the early detection of breast cancer that we have performed fairly well, increase in mammographic coverage that is still very low, from 12% to 24% in the last year. Increase for prostate cancer that we have performed better, an increase in colon cancer, that is a type of cancer that is growing in the last years, and we now have a detection in the early stage in 45% of our population. Next one, please. The other area is the attention and overcoming of the damage caused by cancer. We have experienced decreasing the mortality for cervical cancer, the reduction in the opportunity times between the clinical suspicion of cancer and the diagnosis by 2015, 50% of patients took up to 59 days to be diagnosed. In 2019, 50% took just 32 days, but still we need to improve in the opportunity for treatment. The standardization of clinical care and management, 14 clinical practice guidelines, and 9 comprehensive health cancer routes have been implemented. This is very important for the policy in Colombia because in the way to get comprehensive treatment, we need to be decided to produce healthcare routes that every patient in the country should follow with in each type of cancer to get a comprehensive treatment. And the financing with all, we have assured the financing of all technologies with scientific evidence through a comprehensive health benefit plans that cover radiotherapy, covers medical treatment, surgical treatments, and all the treatment for cancer. This is not a big issue because the insurance policies cover all the cancer treatment, but the performing in the fragmentation of services is the big challenge right now. We also have developed guidelines for comprehensive attention for palliative care and rehabilitation for cancer patients. Next, please. What are the large innovations that we think we have performed? Next one, please. I will say one important issue, very important issue has been the technical cooperation with the International Atomic Energy Organization. That when I was 6 years ago Deputy Minister of Health, I can start the cooperation, a large cooperation with the agency, looking for the expansion of nuclear medical services, radiopharmacies, intensive modular radiotherapy, and the evaluation of our national cancer policy. The other area that we are working on innovation are the payment for results that we are performing right now. Developing financial incentives for the individual risk management by insurers in the 11 most frequent types of cancer in our country. The standardization of risk management that include the process for the development of the comprehensive health cancer routes, the pathways that we think will assure the comprehensive treatments, the development of innovative technologies for early detections that includes in cervix cell assessment, in HPV liquid-based diagnosis, in gastric non-invasive techniques for detection for Helicobacter pylori disease, and in colon immunochemistry in the stool of the patients of the population. The next area for innovation is the program for quality assurance. We have developed that for radiology and radiotherapy, starting with mammography. And these are maybe the areas of that we have performed better in the last few years. Next one. Next, please. What are the challenges? We need to increase the vaccine coverage for human-based papillomavirus, increase early detection of breast cancer, increase the opportunity of starting treatments, reduce mortality for cervical cancer, of course, and increase the social support for children with cancer. We have an extensive rural area in Colombia, and sometimes the treatments for children are stopped because we don't have the social service support enough to maintain the families and to assure that the mothers and the fathers of these children can stay with them and can bring the patients from the rural areas to the health centers, cancer health centers to be treated. And this is also an important challenge. Next one. I will say by the end that, as Rafael talked, that another area for innovation in Colombia that we want to start in the next future and to want to work a lot is the area of artificial intelligence. We think that we need develop artificial intelligence technologies to detect patients, to work on databases. Colombia has very good databases right now for the data mining for patients and to get patients and to assure and to follow treatments and to detect the patients in the early stages of treatments or high risk for to include in the treatment track very easily, and of course to work in areas where we can integrate technologies in a health services strategy with the integration of comprehensive networks for cancer treatment in some areas, especially rural areas for our country. These are my main remarks about cancer. We are very eager to work with the agency and all the initiatives for the development of cancer. And of course, Colombia is now at the door, very close to the increase in the next future for new cases, and uh, we expect that in the next 10 years we will be close uh, to 300,000 new cases per year. So this is a big challenge, and we need to grow in our capacity very rapidly to get to cope with the issues that we have with this disease. Thank you very much.
Many thanks, Minister Gomez. It's refreshing to see you be very honest about where you are, but also very determined in where you're going next. So thank you very much. I'm sure many of us in the cancer community will be motivated to see the immediate impact of the focus on early detection and screening, followed by treatment, that you've already showing some progress on, and also your attention to financial protection for improving access for all communities. Could I just ask you one question? What about collaboration with civil society organizations, non-government groups? How is that working in Colombia?
We have worked very well. We have an integrated system that include private and public services. Both are integrated. So subsidized person, for example, a poor subsidized person who has a subsidized insurance in Colombia could go to the best private service in Colombia, and also we can go to the public services. But most of private initiatives have been developed at NGOs and so a foundation and other kind of institution. We now have it developed in Cali, and a special program to do this city, Cali, our third largest city, a city, the city that is including the cancer challenge and other initiatives that we are very working with them. So we have a very strong collaboration with NGO and other kind of the social civil service institutions.
Thank you, Your Excellency, Minister of Health of Colombia. Now moving to Bangladesh, I'd like to introduce you to Dr. Sanawar Hossain, Chairman of the Bangladesh Atomic Energy Commission. Dr. Sanawar, Bangladesh has a population of 166 million people currently, and I think around 1.5 million new cases of cancer annually. So how is Bangladesh responding to the challenge of providing cancer care?
Thank you very much, Dr. Julie, for your nice question. And Honorable DG IAEA, His Excellency Dr. Rafael Marino Grossi, Honorable Minister of Health, Colombia, His Excellency Dr. Ruiz Gomez, and distinguished speakers, the learned audience, and ladies and gentlemen, this is my great pleasure to be here in this very important Health Summit 2020. And as you have rightly mentioned about the huge population in our country in the context of the cancer care, and Bangladesh is really struggling with the defined cancer control program. As you know, Bangladesh, the incidence of the cancer is like every year, 2 lakh new cases are being diagnosed, and 1.5 lakhs patients are dying each year. And the cancer is the 6th highest incidence of death in our country. And these diagnosed cancer patients, maybe after 5 years, they are dying after the diagnosis. So it's a huge burden in our country. And we have a definite cancer control strategy in our country. And even though Bangladesh Atomic Energy Commission is playing a vital role, and regarding the peaceful use of nuclear energy, nuclear technology in making the preparation and planning of this national cancer control strategic plan. As you know that Bangladesh Atomic Energy Commission has become the member of International Atomic Energy Agency in 1973. It's long back. And we are collaborating in the research and this technology transfer with International Atomic Energy Agency since many years. And through the different technical project, TC project, RCA project, we are actually preparing our manpower for the skill development, and still the facilities are not actually the more enough to tackle these huge burden of the cancer population in our country, because only 57 cancer facilities are available in our country right now, although this demand is more than 300. So it is too much low, still we are struggling. And with the assistance of IAEA, you'll be happy to know that by this few years, we have trained hundreds of manpower, basically in radiation oncologists, medical physicists, radiation technologists, and other technical staffs with the help of TC projects of IAEA. And a significant progress has been made with the assistance of IAEA. And we are trying to combat this cancer burden in our country. And along with this few collaboration from others like civil societies and NGOs, I think we need further assistance from IAEA and other organizations like Islamic Development Bank, because as Honorable DGIE has mentioned rightly, that the cancer scenario in women in developing countries very alarming. It's the same scenario in our country. There's a significant number of women are suffering from cancer breast and CS cervix. And to combat this situation, we need much more collaboration like Islamic Development Bank and others organizations as well. And if we try to collaborate with these international bodies along with our national government levels and NGOs, we can actually, maybe we can try our level best to tackle this alarming situation to control effectively the present scenario to effectively manage the cancer patients in our country. I think the facilities, limited facilities of cancer control, along with the financial assistance is low here in our country, and the awareness of the peoples. These are the major lackings of the effective cancer control program in our country. So we are trying to address these issues to effectively control the cancer, because we would like to ensure the easy access of all the patients, whatever they are having the financial condition or where they used to live. We want to make sure the easy access of quality cancer care in every centers for the each and every cancer patients in our country. Thank you very much.
Thank you. Can I quickly bring in Supriya Chopra here, because I understand, Professor Chopra, that your center in Mumbai has been involved with the technical assistance work in Bangladesh. So what's your outsider view of progress made in Bangladesh in the last few years?
So I think before I talk about Tata Memorial Center, I would like to enumerate that this cooperation happened under the umbrella of IAEA. So IAEA set up a technical cooperation program with Bangladesh and got in a lot of experts from various world regions, and Tata Memorial Center also participated in that. And I think in last 5 years, from when we started, I think it was around 2013 and 14. And I think we have seen very, very positive developments in the quality of radiotherapy in few centers in Bangladesh, and the colleagues through IAEA, and also more like, because it's a community building process, directly also remain in lot of touch for cancer care management. So I think it's a fantastic example of how Bangladesh, IAEA, and some centers in the region came together to foster cancer care.
Thank you, Chopra. So Dr. Sanawal, is it good to hear from outsiders that you're making good progress?
Yeah, thank you so much. We are trying to collaborate further for the further advancement of the quality service of the cancer patients in our country. As you have already come to know that Dr. Supriya has rightly pointed out, and we have actually many experts from IAEA during these 5 years. From 12 countries, around 43 IAEA experts visited our country to train our manpower here. These manpowers are radiation oncologists, medical physicists, and radiation technologists, and along with some other aspects of good cancer care. So right now, the facilities, so far we are utilizing, we are trying to render the good quality care service to the cancer patients, but we are struggling with the huge number of cancer breast patients and CS cervix patients in women, because you know so many cancer patients are basically women with cancers are living in the rural areas. So we'll have to render the cancer care services in the peripheral cities. So I need further international collaborations. And I would like to express my thanks and gratitude to the Honorable Director General of IAEA for his excellent support for Bangladesh as well as in other developing countries. I think it will be a very good opportunity for Bangladesh to work together with other developing countries to render the effective quality services of the cancer patients through this region. Thank you very much.
Thank you very much, Dr. Sanevoix. I think it's a good time now to bring in our second co-host. I'd like to introduce Dal Wilson, Chief Executive Officer of Varian Medical Systems. Dal, thank you very much for hosting this session at the World Health Summit. Could you introduce Varian in one or two short sentences for those that don't know the company, and then talk about how Varian is working in partnership, and maybe give a couple of examples in specific countries of projects that you're supporting?
Sure. Thank you, Julie, and thank you to Director General Grossi, Minister Gomez, and the rest of this esteemed panel. Clearly each market presents a unique set of challenges and opportunities in the fight against cancer. Our vision as a company is to imagine a world without the fear of cancer. That's our vision, and what pushes us to innovate and create solutions that increase access to high quality cancer care everywhere in the world. We are, as most of you know, the world's leading radiation oncology device manufacturer. Our solutions are used to treat about 4.3 million patients a year. We've seen tremendous growth in that patient count, I'd say over the last 4 or 5 years, especially in low and middle income countries. And that's very gratifying to see that access improving, while at the same time acknowledging that we've got a long way to go. And of course, all complicated by the pandemic. We're working very hard to ensure that our customers' patients have access to cancer-saving technology, and at the same time protect the oncology workforce. To answer your question, how can we work with the IAEA and with local governments? A lot of successes. We're committed to increasing access to cancer care around the world. But as I mentioned before, we can't do this without strong government partners and willing international institutions. We do this through public-private partnerships in low and middle income countries, not only to provide equipment, but also to provide services necessary to deliver high quality radiation therapy. So as an example, we're partnering with the Minister of Health in Uganda, Groote Hospital in South Africa, and the University of California in San Diego to complete a training program on capacity building that focuses on bringing the radiation therapy team in Uganda from 2D to 3D and IMRT technologies. Very impressive initiative. When we think about women's cancers in particular, and you've heard about the importance of that here this morning from the panel, it's important that we look at the spectrum of care, in this particular case from diagnostics to treatment to survivorship to prevention. Early detection and diagnosis are key in order to get the best treatment on time. And in fact, if that diagnosis is made early, we can really have a dramatic impact on outcome. But reality is we're dealing with a generation of women who are dealing with cancer today, and we are well placed to ensure that they do receive the best care. So what can we do to combat this? As a company, we need to effectively showcase the value of radiotherapy, whether this is with governments or international organizations, educating stakeholders on the importance of radiotherapy. You've heard a lot about that this morning, on training technicians on the latest techniques. We need to continue the education campaign for radiation therapy. From a partnership perspective, we need initiatives to have clearly identified objectives for private sector collaborations, especially on training and education. Governments need to understand the benefits of investing in radiation therapy and development banks to unlock financing to make cancer care even more accessible in low and middle income countries. And we need international institutions like the IAEA to continue to serve as knowledge partners. The great job they've done utilizing their influence to advance innovative cancer care solutions.
Thanks very much for that, Dal. Let me jump now to Africa and Dr. Bello Abubakar. We know sorry, I should introduce you first, Bello, as the President-elect of the African Organization for Research and Training in Cancer, formerly known as AORTIC, and also radiation oncologist from Nigeria. Bello, we know that the number and quality of national cancer control plans across Africa is improving. So, but how well is are radiation services positioned within those cancer plans?
So thank you very much, Julie. Thank you for having me here, Director General of IAEA and all other eminent persons here present. The African Organization for Research and Training in Cancer is one of the organizations that look at all the parameters of continuum of cancer care, and one of which is the cancer control plans across Africa. We have made a tremendous progress in the last 10 years that we have, at the time, less than 10 cancer control programs across 54 countries in sub-Saharan Africa. Now we have about 30. So in other words, we have about 22 African countries that still don't have cancer control programs. And not only do we have also cancer control programs, but we are making progress in implementation. Already, Dr. Wilson has made mention of the program in Uganda, so I will not allude to that. There's yet another one also in Nigeria, which Varian has also supported. We also have so many programs. I will give an example of the Ethiopian program, where they have not only created the cancer control program, but they have also started implementation. And radiation therapy is quite key, considering the fact that about 70% of our cancer patients will require radiation therapy at one point of their treatment. So yeah, Ethiopia have gone forward to procure new radiotherapy machines, state of the art. And not only that, they have also ensured that there will be maintenance programs. You know, some of the problems we've always had is maintenance. You know, it's not enough to have just the radiotherapy equipment, but you must have also a maintenance agreement. So they've gone forward to have a minimum of 10 years maintenance agreement. At the same time, they are also training capacity, people that will run those equipments. So while they are procuring equipment, at the same time, pari passu, they are also training radiation oncologists, medical oncologists, therapy radiographers, and so on and so forth. The same thing goes for Rwanda, that have also, procured some couple of radiation therapy machines, and they are in the process of getting more. They have already installed 2 brand new linear accelerators in the military hospital, and they have trained also therapy radiographers as well as radiation oncologists. So we are moving forward, but still there are many countries that don't have a single radiation therapy machine. In other words, many countries will require the services of radiation therapy. You will be surprised that a country like Nigeria that has a population of about 200 million people have less than 10 radiation therapy machines, while we will be requiring a minimum of like 200. So it's grossly inadequate, but government and even non-governmental organizations are moving forward to see that they actually develop more capacity for radiation therapy. Already the Ministry of Health is trying to procure additional 14 radiation therapy machines in the next 1 year. I think this is a giant leap, and it should be encouraged not only by the IAEA, but also by the manufacturers. And that leads me to the fact that we at IOTIC are trying to work with the American Cancer Society to see how we can engage industry to lease machines, because it's quite difficult to have a bunker, a radiotherapy machine all under one sweep. Some countries cannot simply afford it. So we want to see how we can engage the industry to see how they can lease some of these machines, because the population is there and people are paying, people are traveling around the world for treatment and they pay out of pocket. So if industry will support us, we should be able to engage some of the Ministries of Health to see how we can get some machines in terms of leasing, and that I'm sure will go a long way in providing radiotherapy facility for the rest of sub-Saharan Africa.
Thank you very much, Dr. Bello. And what about the skills gap? You've mentioned that, and that you need to develop these multidisciplinary teams that Dr. Sanavwar also spoke about in Bangladesh. Does aortic have a role about taking that forward regionally and being able to showcase and use the expertise in countries that are doing well? You know, some of those you mentioned, Ethiopia, Rwanda, use that expertise to help others across Africa.
So absolutely, and that is one of the other key areas that we are partnering, not only with other African countries, but with the IAEA. With their support, we've been able to get fellowships, and people are going from one country to another for training. The first that came to mind is Egypt. They have one of the robust facilities in terms of radiation therapy, in terms of training, and also South Africa. So people, we've been engaging some of the institutions to see how they can actually train people so that they can not only stay there, but they go back to their countries so that they can also impact well in terms of treatment. You know that our organization is, one of the key things we do is training. But training now has to be concerted in such a way that when people are trained, they don't stay there. Until now, a lot of the people that were trained stay in Europe, stay in America, and they don't come back. We want to make sure that anybody that is trained is coming back to Africa to really work for our people. So yes, we are working on that. And because of that, we are also reaching out to the African Union in collaboration with other organizations like the African Commission on Nuclear Energy, because there is a program, which I will enumerate later, on provision of brachytherapy for cervical cancer that we want to actually start together with them. And of course, there are other like-minded organizations that want to also support us in terms of training. So training is very key. And like I mentioned, it is important that anywhere we're getting a radiotherapy machine, the training goes together pari passu, so that by the time you finish your bunker, you finish your installation, then you will have people that will be able to manage. It is not good enough to have facilities and then you are unable to actually use the facilities and get the people locally to manage those facilities. So yes, we are working on that, and we will want to implore all the other people here to support the endeavor that IOTIC is doing so that we can move this agenda forward.
Thank you very much, Dr. Bello, and it's good to hear that AORTIC is focusing on the training, but also having a key advocacy role in the region, and I wish you the best of luck with the work with the African Union. So I'd like to now formally introduce Dr. Supriya Chopra. She's Professor of Radiation Oncology at the Tata Memorial Centre in Mumbai, India. Supriya, we've spoken about countries that are just getting started to build their radiation services. The National Cancer Grid of India is a network of over 250 cancer centres across the country. Could you give us some examples of the work being done to expand services and explain how you're ensuring a quality of both the education that we've been talking about with Dr. Bello, but also the quality of services?
Yeah, excellent question, Julie. So I think the journey of cancer treatment in India in last 3 decades, I think there have been a lot of lessons. And what we've learned from successful countries is their ability to get people together and to homogenize the level of care. So National Cancer Grid program, it originated, at Tata Memorial Center in partnership, but it's not Tata Memorial Center. It's about, getting everyone on the same page, get everyone into agreement, and then make sure that they implement the same level of care. Because I think the biggest challenge is not in making guidelines, not in knowing what's the right thing to do, but it's how you do it at ground level. So I can give you an example that we are now a 200 center consortium, but not every center is equal. So I kind of lead the cervix cancer homogenization initiative within the National Cancer Grid. And what we are doing is that in 2018, we published our guidelines because they had to be practical to a low middle income country. But now we have a rollout project, which was also one of the showcase projects, both for my tenure in UICC as a young leader and also now with collaboration with IAEA, where we are trying to, just map how well the care is implemented. And within this initiative, we also mapped national level resources, which again now went on to become a broader project, also in collaboration with IAEA, where we are trying to map the resources, taking a step back and talking how National Cancer Grid is implementing it. It is by having weekly tumor boards, it's by having semi-annual meetings, it's by having active collaboration and interaction with all participating sites where many people are stakeholder. It's not Tata Memorial Center, but all other centers which are there, they become stakeholders. And the other very important thing that National Cancer Grid of India is doing is trying to, bring in the importance of having access to care. And in partnership, I think with Tata Trust and, for example, Varian, there is a signage which says that, okay, we will build in a certain number of centers in Northeast of India together. So there are various things which are happening with NCG, and there's also a collaboration with IAEA where you try to, take it at a more global scale. So there are many, many things that are happening with National Cancer Grid, but the key points are getting everyone on the same board, making people stakeholders, take responsibility, and try to implement a certain standard of care across centers.
Thank you very much, Supriya. Let's move to Mexico now, and let me introduce you to Dr. Osvaldo Garcia Perez, Head of Nuclear Medicine Department and Molecular Imaging at the National Cancer Institute of Mexico. Dr. Garcia Perez, what about expansion of services in Mexico? How are you responding to the challenge of providing equitable care in a large and diverse country such as Mexico?
Hi, really, it's very complex, the situation in Mexico, because at the beginning, all the health systems are very centralized. So that we are looking for is create satellite units that can be used for attend different regions of the country with the same quality, with the same quality control that make sure that all the patients have the same kind of attention, same kind of drugs, or radiotherapy, kind of diagnostic studies, and all that other stuff. So I think it's my lecture. Well, Mexico, as you know, is a country with almost 130 million inhabitants and has a health system, as I told you previously, made up of 5 subsystems. This hyperfragmentation of the health system implies that not all the people doesn't have the same kind of therapeutic and diagnostic options. So there's a very big problem. For example, in income, in our hospital or in a private hospital that can be used for insurance companies, a patient with lung cancer, for example, can, with locally advanced cancer, with locally advanced disease, may have a biopsy, complete immunohistochemical profile, molecular profile, even an PET-CT, and only in the first week, and probably could be carried out to immunotherapy or surgery in the second week. In another hospital that maybe social security like IMSS or like ISTE, it can reach until 3 months to the same attention, even in some hospitals, there is no immunohistochemical studies. Of course, there is not PET-CT, and of course, there is not radiotherapy. So it's very difficult to attend the patient in this way. So there is in Mexico, the Senate has created some kind of special programs that give fees for attend certain kind of population with very, very low income. So it can help that people with very poor that can have access to this kind of treatment. So can you next slide, please? So thanks to the support of the International Atomic Agency in collaboration with PAC and WHO, the impact mission was carried out in 2018. The final report makes a very detailed observation about this inequity between all the health systems. For example, it's a very interesting date. For example, only 50% of the radiotherapy units that exist in the country belong to the sector public. With a very similar problem happened with highly specialized equipment like PET-CT technology that has been increasing its demand due to implementation in the NCC guidelines and European guidelines and Mexican or national guidelines. So in Mexico, we only have 45 PET-CT units, and only 5 units belongs to the public sector. So it's a very big problem because not all the patients has access to this kind of study. And the most important is that this kind of this health system implies that, for example, of 75 million patients that are attended by IMSS, there is no one PET-CT unit. The second social security subsystem that is called ISTE only have one PET-CT, and the other on the most of the device belongs to the sector public. So it's very, very, very interesting because, for example, as you know, can you please the next slide, please? As you know, PET-CT in locally advanced disease allow change about 25% of the patients. So it is very, very important because if we analyze the cost efficiency of this kind of this modality of studies, the government can save between $780 until $3,015 according to the type of cancer. So can you see, if you see the previous image in the mammography, we complement with a PET-CT. It's very, very interesting because when we make an approach using only conventional modalities, we can carry to the patient with a more conservative treatment. So what happens when we add the PET-CT, we can identify more lesions that can be seen easily with the conventional modality. So this is the same when we try to evaluate lymph nodes or metastatic disease that can present unsuspectedly and change, of course, the therapeutic approach until 25%, as I told you previously. So can you next slide, please? So the intention of this lecture is highlight the role of the innovative technologies like PET-CT in cancer control and how the IAEA has collaborated and has supported with us. So in two years ago, the support of the MEX 6009 project was possible to train doctors from northern regions of the country, southeastern regions of the country. They went to Germany and Austria. Also, we used 3 scientific visits to Chile to capacitate in the use of new techniques to label or to synthesize FDG or another radionuclide. So also the IAEA give us one chromatography, liquid chromatography, and what module synthesis. What happened, or what's the main intention, or how it impact our service? Well, This action allowed to increase productivity through better training, the centralizing of certain several services. So we are looking for established programs for the exchange between health service like PET-CT, like radiotherapy, that, as I told you previously, the subsystems healthcare don't have access to this kind of technology. Also, and additionally to this, or the advantage of the benefits of this collaboration between AEA is the pediatric patients also has been benefited. Why? How they can be, we start to give them pediatric population access to treatment with radionuclides for thyroid cancer, for neuroblastoma, for another kind of these neoplasms that originate from the neural crest. And also they have access to MRI studies, to PET-CT studies, that obviously they have a benefit. So can you share the next slide, please? Also, and I forgot to mention that, for example, in the northern region of the country, we start to replace, with, in association with the AEA, cobalt therapy for a LINAC therapy. That is very, very important, because the number of patients that can be benefited for this kind of service in the northern region of the country, when there is no one radiotherapy unit, is very, very big, because there is at least 1/3 of the total population in the northern region. So what's the planning? What we need, or where we think that, how we are going to work with this kind of initiative is exchange the diagnostic and therapeutic service between health subsystems to increase the access, increase human resources that can make possible that the treatment, or is it related to radio-oncology, medical oncology, surgical oncology, nuclear medicine oncologists, to be sure that the same quality of treatment that the patient needs in the northern, in the southern, or in the southeastern of the country has the same quality. So the government are looking for set up a global coverage of health services without any cost to the population. So that's all my participation. So I don't know if you have any.
Thank you very much, Dr. Garcia Perez. I'm just looking at the time here. You want to touch on brachytherapy, so very quickly then, could I go to Supriya Chopra? We have a question in the chat, Supriya, which you might be able to address at the same time, asking about how do you make, or how do you develop the case for strategic investment decisions for diagnostics and radiotherapy versus other areas in cancer, or beyond cancer, of course, with your government? And maybe we can take the perspective of cervical cancer here. Just this summer, we saw the adoption of the WHO Global Strategy towards the elimination of cervical cancer. It's a huge step forward, representing the first time the global health community has made a commitment of this type to cancer control. So yeah, how can we use initiatives like this, Supriya, to make the right investments to move care on the ground forward?
So, Julie, as all of us are aware, 70 to 80% of cervix cancer will present in locally advanced stage, especially in low middle income countries. And brachytherapy, or internal radiation, is a crucial component. In the absence of brachytherapy, you cannot cure a woman with cervix cancer. So we did this exercise in India, where we realized that we are at least 52 units short of the brachytherapy equipment. Now, the question is, how do you make the case to the government? So what we've started doing is that by investing in brachytherapy, the life we are saved. So we looked into, our employment status of women in India and what they contribute to economy, and did the cost investments for brachytherapy. And what we realized is that within 2 or 3 years, the costs can be recovered of brachytherapy. So for governments, and to explain to governments, I think economics is needed. Otherwise, you can't make a case to the government as to how a particular equipment is going to improve the health of the country. So for example, in India, 20 to 30% of the women were working and contributing a certain amount to the economy. And we weighed it against, the cost investment for brachytherapy, and it's a win-win situation. And also because now there's so much of focus on cervical cancer, with cervical cancer mortality exceeding maternal mortality, I think the time is right to make a case. But I think the sad part is when you look into the national cancer control plans, and you are a co-author on that paper, where less than 50% of the countries actually list the word radiotherapy in their national cancer control plans. So brachytherapy is even a step behind. So first, I think all the governments and all the advocates have to start listing radiotherapy as an essential part. And then obviously now with focus on cervix cancer, account for brachytherapy. And
Thanks
just to
very much.
mention, yeah. No, we're just doing this activity-based costing with IAEA as part of the CRP, and we are going to come up with some costings about, how you invest in brachytherapy and how useful it can be for various institutions and governments.
Thanks very much, Supriya. So very much focusing on the capacity of using these tools that are being generated internationally on costing and investment to really bring the capacity in country to move that forward. I'm hand over to Anya, my co-moderator. Anya, have we got any particular question coming through that you'd like to squeeze in? We have now about 10 minutes left.
Yes, thank you so much, Julie. There's a lot of questions that are coming in, and thank you so much also to the very active audience that is listening in and also sharing questions and opinions. I would like to pick up one issue, and maybe that could be a question to Dr. Bello Abubakar. It relates to a question from Ankita Parvi. She is asking that she had heard that radiotherapy can actually safely being provided also in times of COVID-19. That's something she has heard, and she wants to hear your opinion and whether there's any innovations that have been applied recently that could also help us in the future. Dr. Bello?
Well, thank you very much for that question. Yes, radiotherapy can comfortably be administered at the time of COVID, making sure that you have put in all the key important preventive measures, especially for the patients, considering the fact that most cancer patients tend to be more vulnerable to the the coronavirus. So yes, even in our environment here, we have put in so many preventive measures. We make sure that there is no crowding that we used to have, for patients. So patients only present an appointment. There is minimum contact with both the staff and the patients as much as possible, sanitizing all the time and making sure that all environments are cleaned. Yes, so that is very key. And we have not closed any of our facilities, our radiation therapy facilities, especially at the time of the COVID pandemic. Of course, here in sub-Saharan Africa, the coronavirus pandemic is actually regressing to an extent. If we are going to have the second wave, we are putting everything in place to make sure that we are not taken unawares, and our patients are also sensitized on the need to have, social distancing, face masking, and so on and so forth. And innovative ways of contacting also their doctors. We have so many organizations that are coming up like in Nigeria, we have what is called Oncopadi. It's an app that patients can actually access their clinicians and give them, information. There's also the Mobi Health, where you can actually consult your doctors, online before, so that you don't need all the time to go to the clinics. So all these things are technology that are being used to make sure that you have minimal contact with the hospitals. So I think that answers your question.
And Anya, if I might just add real briefly, we have thousands of institutions worldwide delivering cancer care very successfully in the pandemic. There was a lot of education early on that went on. We can certainly help people with that. I'd say the other thing that I'd just add, Bulab mentioned it briefly, but this whole realm of telehealth is very important, and we're seeing on the education side, people completing remote training, performing consults, survivorship appointments, follow-up appointments, and then of course treatment planning as well. So we're seeing a lot. I'd say one of the things that COVID has done is it's in fact accelerated the adoption of telehealth. Certainly, patients have to come, as Bola pointed out, to the care center for the care itself. But could we remove the rest of the burden from a technology point of view? We're seeing that trend big time.
Thank you very much for that, Darren. It's good news that radiotherapy services can continue. So I see that we're slowly coming to the end. The 90 minutes have whizzed by. So let's go back to DG Grossi for any remarks on COVID-19 and the study you mentioned at the beginning. And otherwise, I think maybe to close the session, in fact.
Thank you very much. It's been really, like you said, these 90 minutes flew away. There's so much we could comment on, really, and every contribution brings more topics one would like to address. I can say this: it is obvious that we have, I think, a common approach, and the same. We are drawing from our different perspective, roughly the same conclusions. We know where the problems lie. We know what is needed. We even know, and I'm very grateful for the very candid national presentations we had from our Colombian, Mexican, Bangladeshi, and Nigerian friends. It is amazing how transparent we all are. And the reason is because we all know that in this area, posturing is absolutely the wrong thing to do, and we need to see things as they are. That being said, I think we must, if I may, recommit ourselves and say to ourselves that we are in a sort of a plateau that should not continue like this. It is clear, and it has been the case for quite a while, that we are recognizing these things, and it is okay to remind ourselves about these self-evident realities of half a continent not having access, or what can be done here or there. I think what we need to do, and this is one of the conclusions at least personally I take, is that all of these partnerships we have been establishing, we should try to put them at a higher level. From my perspective, and I think it has been mentioned by Dr. Hossein, for example, where he was referring to what we are trying to do with the Islamic Development Bank. I think, at least from the IAEA, and Anya and her team from PACT have very clear indications from me, in the sense that we have to multiply these partnerships, and you and others in the international cancer community could help us in passing the message. There are other regional development banks that have not been approached so efficiently, and we must occupy those spaces. I think we need to have better figures to show for next time around. So I would say let's make ourselves this commitment that we need to do more, we need to do better. We cannot continue hovering this gloomy statistics of a continent with half of the countries not having access to one single unit. The generosity of Dow and Varian and others in the private sector is also indispensable to move in this regard. All I can say is that the community can continue to count on the IAEA. We'll be there with you every step of the way because the fight goes on. I would like to thank you for this opportunity, for this excellent exchange with so many valuable partners and friends. There's a lot to be done, Julie. So let's roll up our sleeves and get on with the work.
I think that's an excellent ending sentence. I'm more than happy to roll up my sleeves with you. So thank you very much also to Varian Medical Systems as co-host. Thank you very much to our panelists, and thank you very much to our audience and your interactive participation. This session will be recorded, so if you'd like to revisit, it will be available on the World Health Summit webpage. Thank you very much. Goodbye,
Thank
everyone.
you all. Thank you all. Stay safe.
Thank you so much.
Thank you.
Thank you, Julie. Thank you, everybody.